جمال مرسي من اسكندرية، وسعيد ان انا اكون وسطيكم النهارده عشان to discuss together البروبلم اللي دايما بتواجهنا كاورثوبيديك سيرجن about the wrist and hand fractures. كتير مننا او زمان لما كنا نواب كنا عندنا مشكلة في الريست fractures، والواحد لازم يعترف دلوقتي طبعا ان الدنيا اتغيرت خالص عن زمان في الريست والهاند fractures. كلكم صباح الخير في الاول، طبعا دلوقتي بقينا الظهر خلاص. We will start first with the wrist fractures. We all know that the wrist fracture is the most common fracture of the upper extremity. It constitutes 15 to 20% of all fractures, and about 50% of these fractures involve the articular surface. ومن هنا جت أهمية إن إحنا to deal with the wrist fracture. The wrist fracture occurs in two distinct age groups. The first is the young group, 6 to 10 years old, and the second is the old group, 16 to 70 years old. It's more common in women and about 7 times greater in older population. We all know that the wrist is formed by articulation between the radius and ulna together with the carpal bones. And there are 8 carpal bones distributed in 2 rows, proximal and distal carpal rows. The proximal carpal row, scaphoid, leonate, triquetrium, bisiform. The second, or the distal, trapezium, trapezoid, capitate, hamate. And here is the rows, proximal row and distal row. وكنا زمان بنجد صعوبة في حفظهم، فعلمونا to use the first letter from this abbreviation. Some leaders try positions that they can't handle. Sorry. عشان نحفظهم، ولو صعب علينا نحفظهم كده ممكن نحفظهم بطريقة أظرف. سامية لمعي، تلعب بوكر، تخسر تكسب، كله هلس. فنحفظ الحروف سكافويد، ليونيت، ترايكويتريوم، بيزيفورم، ترابيزيوم، ترابيزويد، كابيتيت، هاميت. أنا مش عارف حد بس يسأل لنا حكاية اللعب بتاع دي على طول كده ولا في بروبلم في And here is the lateral view. This is the distal radius, this is the leonate, this is the scaphoid, and this is the capitate. لازم نعرف النورمال anatomy. مقفولة هو قافلها. Okay, خلاص. We hope it works. وفي شوية relations في الديستال radius. anatomical relations لازم should be put in mind. لازم نعرف النورمال عشان to consider the abnormal، او لو جاء fracture واحنا بنعمل reduction لازم نعرف ايه اللي accepted وايه اللي ما ينفعش. فالديستال radius has 3 important things: radial inclination which is about 20 degrees, palmar tilt of the distal radius which is about 11 degrees, and the radial length about 11 millimeter from the ulna. These 3 important things should be put in mind. And there is also scaphoid and leonate facets. Here is the radial height. And this is the radial inclination. And this is the palmar tilt of the distal radius. مهم قوي الكلام ده عشان لما نيجي نعمل reduction لأي fracture لازم to reach an accepted position. This is the normal anatomy. Bones, 2 rows, ligaments, lot of ligaments stabilize the wrist. And if we discuss the anatomy of the distal radius, it forms as an articular surface upon which the carpal rests. The distal radius gives origin to the ligament which stabilizes the wrist, and it forms articulation with the ulnar head combined with the triangular fibrocartilage complex. There are three facets in the distal radius: scaphoid facet, leonate facet, and the sigmoid notch. Here is again scaphoid, leonate, sigmoid notch, and here is the triangular fibrocartilage complex. The triangular fibrocartilage complex is a major stabilizer of the ulnar and radioulnar joint. The normal wrist movement is about 150 degrees flexion and extension, 50 degrees radial and ulnar deviation, and 50 degrees pronation and supination. With axial load occurs about 80% through the radius and 20% through the triangular fibrocartilage complex. The diagnosis of distal radial fracture starts with history. As I said, more common in women and in two distinct age groups. The common mode of injury is the fallen outstretched hand. Once you see a fractured distal radius, you should evaluate whether it is open or closed, the degree of soft tissue injury, and if there is a neurovascular injury, especially the median nerve. After clinical evaluation of the patient, we go to the radiology, starting with plain X-ray with the two common views, anteroposterior and lateral views, and sometimes we add oblique view. And if you are in doubt, you should do an X-ray to the contralateral wrist. And in order to determine the degree of extension of fracture, we can do also CT scan. And here is the normal radiograph. This is the plain X-ray, anteroposterior view, and this is the lateral view. In order to treat, you have to classify. There are many classifications for the distal radial fractures. The commonly used is extra-articular or intra-articular. وكل دي حاجات احنا سمعنا عنها. Colles fracture, in which there is dorsal displacement of the distal fragment. Smith fracture, عكسها, volar displacement of the distal fragment. Barton's fracture, which is the radial rim fracture with dislocation of the radiocarpal joint. And sometimes dorsal and sometimes volar. يعني بيبقى فيه chip من الديستال radius fracture ومعاها dislocation للراديوكاربال joint. يبقى ده اسمه بارتون fracture. وحسب التشيب دي رايحة volar تبقى volar بارتون، dorsal يبقى dorsal بارتون. Another classification based on the mechanism of fracture is the Fernand's classification, whether bending fracture, shearing fracture, compression fracture, avulsion fracture, with or without radiocarpal dislocation, and finally combined fracture with the soft tissue injury. And this is another classification based on the mechanism of injury. Third mechanism of Gartland and Worley, based in metaphyseal comminution, intra-articular extension, displacement of the fragments. The recent classification used nowadays is the Mellon classification, and this classification emphasizes the effect of leonate's impaction on the radial articular surface. قسم الدistal radius into four parts: shaft, radial styloid, dorsal medial fragment, palmar medial fragment. وعلى حسب الفراجمنت دي عمل الكلاسيفيكيشن بتاعه، وده هيفرق معانا بعد كده في التريتمنت. And finally the AO classification, which bases on the severity of the bone injury. The treatment. We have to put in mind the acceptable radiographic parameters. Radial length should be 2 to 3 millimeter of the contralateral wrist, not less. Palmar tilt, there is a palmar tilt, but we can accept neutral tilt, but we will not accept any dorsal tilt. We can accept intra-articular step off, but less than 2 millimeter. And finally, the radial angle should be not more than 5 degrees of loss. This is the acceptable radiographic parameters post-reduction of the distal radial fracture. So we do radiographs first at the time of the injury to evaluate the direction of displacement and the amount of angulation, and then we do another X-rays post-reduction to evaluate the comminution, the fracture pattern, and the stability. We have to correct any articular step off, any gap between the fragments, and the radial shortening. This is because 2 millimeter or more of articular incongruity will lead to later post-traumatic arthritis. In the management, we have to put in mind if there is any associated ulnar styloid fracture, the age of the patient, the extent of comminution, and redisplacement after closed reduction. If these are present, this means that this is unstable fracture. The treatment option, many treatment options for distal radial fractures, starting with closed reduction and immobilization in cast, closed reduction and percutaneous K-wire fixation, external fixation, recently arthroscopic assisted reduction. مش عارف على طول continuous عمال يعمل كده. And external fixation, open reduction and plate fixation, and finally bone grafting if there is any comminution or bone loss. وعشان نسهلها أكتر حسب الفراكشر، لو non-articular undisplaced fracture cast immobilization. If it is non-articular but displaced fracture على حسب هل هو reducible وstable يبقى cast again. Reducible but unstable, then we do K-wire fixation for stability. If it is irreducible and even stable, we have to do open reduction and internal fixation. The third type is if it is articular and undisplaced, we can do just cast immobilization or to add for fixation to do percutaneous K-wires. And finally the problem, articular and displaced. If it is reducible and stable fracture, we do closed reduction and K-wires. If it is reducible but unstable, we can do either closed or arthroscopic fixation with or without K-wires or external fixator. But if it is irreducible, we should do open reduction and internal fixation. And finally, with complex fractures with bone loss or comminution, we have to do open reduction and fixation with wires or with or without bone grafting. Here the non-operative with closed reduction and cast immobilization in stable fractures and in old elderly people. The operative treatment, first we can do closed reduction and then stabilization. The indications for operative intervention in distal radial fractures is comminuted, displaced intra-articular fracture, open fractures, associated carpal fractures, associated neurovascular injury, failure of conservative treatment, bilateral fractures, أو impaired contralateral extremity. والmethods احنا قلناها whether percutaneous K-wire fixation, pins and plaster, external fixation, open reduction, and internal fixation. Here the method of the percutaneous fixation. When an external fixator for comminuted fractures. If we decide to do open reduction using plate and screw fixation, we use the patient in a supine position using a tourniquet. We use a volar approach to reach the distal radius. and we put small plate and screws. The complications of the distal radial fractures, whether early complications, nerve injury, especially the median nerve, or reflex sympathetic dystrophy. The late complications involve malunion, delayed and non-union, stiffness, of the wrist, not of the shoulder, psoas atrophy, and tendon rupture of the flexor tendons. بعد ما خلصنا distal radial fracture, then we'll go step forward into the carpal bone fractures. The most common fracture involved the carpal bone is the scaphoid fracture. كلنا عارفين السكافويد بون، وهنعرف دلوقتي هي ليه more vulnerable وايه اهميتها، وهل ليها اهميه ولا لا. العظمه الصغيره اللي هي موجوده اللي ممكن تبقى مزعجه للعيان طول حياته. Scaphoid fracture constitutes about 60 to 70% of all carpal bone fractures. It is uncommon fracture in children because the physis of the distal radius fails first. لما يقع الطفل عادة بيتكسر الابيفيسس بتاعه او الانجري بتحصل through the physis قبل ما توصل للسكافويد. The scaphoid bone is also called the navicular bone، اللي هي شبه الزورقية كده. It is an irregular shaped bone، وهي بتريبريزنت من الاناتومي زي ما كلنا عارفين الفلور اوف ذا اناتوميك سناف بوكس. وزي ما انتم شايفين ان السكافويد بون، حد شايف حاجه ده؟ السكافويد بون هنا بروتكتد بميني ليجامنتس. ليجامنت اسمه في حاجه في هنا اللي بيعمل كل شويه اوتو سيت اب. لا في الجهاز